This talk is about intraoperative motor evoked potential monitoring. It is intended for the Nicklaus Children's Hospital Clinical Neurophysiology Fellows. It will be conducted in a question and answer format. The first question is: failure to detect an event that resulted in a neurological injury is called A, false positive, B, true negative, C, false negative, D, true positive. False negative from the perspective of intraoperative monitoring implies that although all apparently went well during surgery, the patient woke up from anesthesia with a deficit. During a spinal surgery, false negatives are more common when only somatosensory evoked potential is used by itself than when somatosensory evoked potential and motor evoked potentials are used combined. So the answer to this question is C. Next question. Transcranial multi-pulse train stimulation is better than single pulse stimulation to trigger a muscle motor evoked potential. A, true, B, false. Transcranial evoked potential, electrical or magnetic, produce motor evoked potentials that, depending on the recording sites, are called muscle motor evoked potentials, direct or indirect responses if they are collected from the spine, although some authors point out that transcranial magnetic stimulation usually fails to produce indirect responses. And the third type of recording that can be obtained from motor evoked potentials is the nerve motor evoked potential if the potentials are recorded from the nerve. Electrical transcranial stimulation can be achieved by single or train of a stimulus. The intensity for single stimulus must be higher than for trains of a stimuli. The risk of seizure using single transcranial stimulation is also higher than when using a train of stimuli. So the answer to this question is true. Next question. Which of the following statements is not true regarding the optimal stimulus parameter for transcranial generated thinner muscle motor evoked potentials? A, number of pulses 5, B, repetition rate 300 Hz, C, pulse width 1 milliseconds, D, core intensity 100 milliamps. The technical parameters recommended for transcranial electrical muscle motor evoked potential vary from institution to institution, from article to article, and from book to book. This lack of consistency goes from the electrodes used, which range from corkscrew to regular surface electrodes attached with collodium, going through subdermal hook electrodes, to the criteria used to decide what is normal and what is abnormal. Stimulus parameters are not spared from this inconsistency. I think the best recommendations are those in Muller's book and even those are inconsistent because the original paper being quoted for some of the recommendations have different set of recommendations than the one represented in the book. Having said this, I will give you a few pointers based on Dr. Muller's book. For the number of consecutive pulses or stimuli, 5 seems to be the best number. When we use 5 stimuli, one after the other, to provoke one response, we should talk about a train of 5 stimuli or pulses, but we often only say stimulus to refer to the train of a stimuli. Regarding the repetition rate for those 5 stimuli, that is how far apart should the stimulus be from one another within the train, differs from 500 Hz, which corresponds to an interpulse interval of 2 milliseconds, to 300 Hz, which corresponds to an interstimulus interval of 3.3 milliseconds. Probably an interstimulus interval of 3.3 microseconds is the one most used clinically. The duration of the pulse or the pulse width influences the amplitude of the discharge. The longer the pulse, the higher the amplitude of the evoked potential. As you can see, a pulse lasting 0.3 milliseconds produces a smaller discharge or potential than a pulse of 1 milliseconds, but also the pulse of 1 milliseconds tend to be more painful. So a pulse duration of 0.5 milliseconds seems as an appropriate compromise. A pulse of 0.5 milliseconds corresponds to 500 microseconds. The rise time of the pulse should be of 0.05 milliseconds, which corresponds to 50 microseconds. Regarding the polarity of the transcranial stimulation, anodal stimulation is more effective. Current intensity has the same issue as pulse duration. The more we give, the higher the amplitude, but the more it hurts. Despite the fact that when done intraoperatively, the patient is anesthetized and pain will not be perceived, most neurologists prefer to keep the intensity to about 100 milliamps. So the answer to this question is C. Next question. Transcranial multipulse train stimulation intensity is usually reported in microvolts or milliamps. A. True. B. False. Transcranial electrical stimulation should be given in trains of 5. The stimulus intensity should be started at 250 volts, but it may be increased up to 1000 volts in order to be able to record a direct response. If instead of measuring the stimulus intensity in volts, the intensity is given in milliamps, then the usual number quoted is 100 milliamps, as we previously mentioned. The duration of the stimulus should be 0.5 milliseconds with an interstimulus interval of 2 to 3 milliseconds. For the purpose of this frame, I will use 2 milliseconds, thus rendering the duration of the train to 10.5 milliseconds. So the answer to this question is false. Next question. Filters for spinal motor evoked potential direct and indirect responses, and muscle motor evoked potentials are set at the same frequencies, A true, B false. I will use this cartoon to explain spinal motor evoked potentials and muscle motor evoked potentials in general, and I will put a special emphasis on the use of filters. As you can see, I have represented the motor pathway with yellow lines. The magenta rectangle encloses an area corresponding to an open spinal surgery field. This area is expanded on the left side of the screen, as you can see. The blue structure represents the spine. The flaps by the side of the spine correspond to the stretched epidural layer. The stimulus is represented by a red thunder. The color red is meant to remind you that at the site of the intended stimulus we should place the anode of the stimulating device. The stimulus can be given in different scalp sites, as we have discussed in prior video. In this example, it will be placed in such as the anode is 1 centimeters in front of C2 and the cathode is 1 centimeter in front of C1. That is so because the intended cortical area to be stimulated is the right motor area. The pulse duration used in this example was 500 microseconds. The voltage 250 volts, and the stimulus interval was 4 milliseconds. The searching electrodes were placed on the epidural layer close to the spinal cord. The reference electrode was placed distally in a nearby quiet area within the surgical field. Notice I have added the two electrodes in the main figure, which I have previously placed in the larger figure. I have now added an amplifier joining the electrodes from the spinal monitoring site. The amplifier represents a differential amplifier, despite that only 2 prongs are being represented in this figure. Now I have added a low frequency filter and a high frequency filter. I have now placed the specification for each of these filters. The low frequency filter used in a spine recording should be set at 500 Hz and the high frequency filter at 10,000 Hz. A wave form collected using these filter specifications is shown on the left bottom area of the frame. The arrow points to the stimulus artifact, which includes all the shaded area. The thin wave that on its way down crosses the midline is the direct response. The term direct means that it is produced by the effect of the stimulus, in this case the electrical field, upon the pyramidal neurons. These are the neurons that are believed to generate the D response. The following 2 lower amplitude waves are called the direct response. They are also generated by pyramidal cells. They are called the indirect response because they are produced by a different mechanism than the direct response. The difference is that the indirect response results from transsynaptic activation of the pyramidal cells by neighboring neurons that become activated by the original stimulus. and not by the pyramidal cells directly being stimulated by the stimuli. The important parameter, if there is any, is the amplitude of the D wave. But for most neurophysiologists, the only clinically significant question is the presence or absence of the D wave. If D wave is present, it's normal. If D wave is absent, it is abnormal. In this new frame, I have added an element to represent the hand muscles. And now I have added an amplifier and the filter setting with the specifications that are used for the muscle recorded potential. Please take a moment to compare these specifications of the filters with the ones that we previously mentioned when we talked about recording from the spine. Notice that filter setting for recording muscle should provide a band path between 30 Hz and 3000 Hz. On the bottom, I have now added on the right side a legend. I will use the area above the legend to show the spinal responses and muscle motor evoked potential responses to single stimulus and to multiple stimuli. Recorded at the cervical epidural region, a single stimulus will produce the expected direct and indirect wave we have just mentioned. Notice that the stimulus artifact, the direct response, here labeled D1, and a few indirect waves labeled I. I have now introduced the recording from the hand muscle, and as you can see, no wave is present. Now we can see a two stimuli train. The indirect response produced by the first stimulation is not seen because it is drowned by the second stimulus artifact, but the D wave of the first stimulus can be seen. We can see that it's been labeled D, and in the second stimuli we can see both. We can see the D, now labeled D2, and also the indirect. Now after 3 stimuli, we can see the muscle motor evoked potential beginning to appear and becoming bigger when the train is of 4 and 5 stimuli. Notice the difference in the muscle motor evoked potential between the third stimuli train, the fourth stimuli train, and the fifth stimuli train. So the answer to this question is B. In this frame, I have placed the filter setting used for spinal recording and muscle motor evoked potential recording side by side so you can see the difference. Next question. Central conduction time can be calculated using H reflex or F waves. A true, B false. As described in a prior video, central conduction time can be determined by successively stimulating the wrist, the spine, and the scalp while recording from the hand muscles. Such procedure can help detect central motor conduction delays, which are sometimes present in patients with multiple sclerosis. This frame belongs to one of those occasions where you can compare the presence of a delayed central motor conduction and a normal central motor conduction. But central conduction time can also be obtained by recording transcranial muscle motor evoked potentials, F wave latency and M wave latency, without the need for spinal stimulation as I will show you in the next few slides. In this frame, I have depicted the M wave latency. The M wave latency is indicated by the letter A. Notice that the cathode in this special situation is placed proximally to the anode. Another block, often talked about, usually does not occur using the stimulus parameter we use in clinical practice. Next, we get the F wave latency by increasing the stimulus intensity. The F wave represents the time it takes for the proximal volley generated under the cathode to reach the motor neuron, the time it takes for the motor neuron to self-activate, and the time it takes for the distally traveling volley from the motor neuron to reach and activate the muscle. The F wave is here represented by the letter B. Now, in order to figure out central conduction time, we need to take 4 steps. These steps are based on the result of the muscle motor evoked potential conduction, the M wave conduction latency, and the F wave conduction time. The first step is to subtract the latency to M wave, that is the value of A, from the value of F wave latency, that is B. The result of this operation should be labeled C. The value labeled C reflects the time it takes for the electrical volley to travel proximally from the cathode to the spine, and the time it takes for the volley to travel back, that is distally, from the spine to the cathode. The next step is to divide C by 2, thus finding the conduction time between the spine and the cathode. The result of this operation is labeled D. The next step is to add D to A, that is, the value representing the conduction time from the motor neuron to the cathode, that is D, to the conduction time from the cathode to the activation of the muscle. This sum will be labeled E. The fourth step is to subtract E from the transcranially generated muscle motor evoked potential latency. The result of this subtraction is the central conduction time. The use of conduction time has been greatly reduced to the point that is now hardly ever done. This is the case because brain and spine MRI have come to the aid of diagnosing multiple sclerosis, whereas in the past we needed to do conduction time in order to get a better idea of what was going on at the level of the spine in patients with multiple sclerosis. So the answer to this question is B. Next question. Which of the following motor evoked potential results has values in the OR? A. Spinal motor evoked potential latency. B. Muscle motor evoked potential threshold. C. Nerve motor evoked potential latency. D. Nerve motor evoked potential amplitude. Theoretically, motor evoked potentials can be analyzed taking into account latency, amplitude, and threshold of their appearance. Yet in the OR, most neurophysiologists I know only call D abnormal when it is absence, that is when it disappears. And the same goes for muscle motor evoked potentials. And for nerve motor evoked potentials too. Most neurophysiologists do not use latency or threshold criteria to call a test abnormal. Other neurophysiologists call a muscle motor evoked potential abnormal if its amplitude drops by 50%, The drop in amplitude is not, to my knowledge, used to call Dwaves or nerve motor evoked potentials abnormal. But I think it's wise to notify the surgeon in the event of such occurrence. Be it as it may, using the 50% criteria to call a muscle motor evoked potential abnormal, we will have 20% of false positives. But on the other hand, we will have 0% of false negative. For clinicians, especially all clinicians, of the three possible parameters that we can measure, latency, amplitude, and threshold, only muscle motor evoked potential latency has some significance, because latency is often used to provide information about central conduction, as we have said a few seconds ago. This chart summarizes the value of transcranial motor evoked potential parameters. Latency, amplitude, and threshold recorded from the spine, muscle, and nerve has a special significance to the different medical specialties. The researchers think some things are important, the clinicians another, and the neurophysiologists in the OR think of other things as being important. So the question are, what are those things? Well, a spinal cord motor evoked potential only has clinical value in the operating room. Its only useful element is amplitude. As investigational tool, spinal cord motor potential latency and threshold has been used outside the OR. This has been done using needles inserted transcutaneously to reach the proximity of the spinal cord. Muscle motor evoked potential has clinical value in the operating room and for the clinical neurologist. In the OR, the reliable element is amplitude. For the clinical neurologist, the reliable element is latency. Threshold is used only by investigators. Nerve motor evoked potential only has clinical value in the operating room. The only parameter used is amplitude. Latency and threshold are used only by researchers. So the answer to this question is D. Next question. Electrodes for muscle motor evoked potential recording are always placed using the belly to tendon technique. A true, B false. I am showing you this frame so you can see the multiple waveform configuration associated with muscle motor evoked responses and the different arrangement used to capture them. Notice that we are collecting the same muscle on the left and on the right, and even being the same muscle with electrode placed at about the same place within the muscle and giving the same stimulus intensity, the look of the waveform is significantly different. Notice how it looks on the left and compare it to how it looks on the right. Also notice that muscle motor evoked potentials are monitored using the belly tendon technique in case of the vastus lateralis and the abductor hallucis, while on other occasions the muscles are monitored by linking two muscles from the same myotome, as you can see it to be, in the case of the abductor pollicis brevis and the abductor dieti minimi, these muscles share C8 and T1 innervation. Therefore, they can be joined together to see the reaction of this myotome. This is the same for the combination of the tibialis anterior and the gastrocnemius. They both share S1 segment. Another muscle often evaluated is the external anal sphincter, which receives fibers from S2, S3, and S4. In this figure, you can see the sacral nerve from S2, S3, and S4 forming the pudendal nerve and the inferior anal nerve, which is a branch of the pudendal nerve that innervates the external anal sphincter. So the answer to this question is false. Next question. Which of the following stimulation sites is the best to produce a D response? The question at hand deals with spinal motor evoked potential, especially with the D response, which is the only one that is clinically significant. The best stimulating electrode position to record a robust D wave varies from person to person. The most often used stimulation sites are for left hemisphere stimulation to place the anode at CP3 and the cathode at CP4, or inverting the polarity of the stimulating device for right hemisphere stimulation. Another stimulation placement often used is CP1 and CP2. And yet another stimulation site often used is to place an electrode 1 centimeter behind ZZ and another electrode 6 centimeters in front of ZZ. Regardless, the location of the electrodes of the discharging device, as we have said multiple times, the polarization is best achieved under the anode. By producing dendrite hyperpolarization, which will lead to axonal depolarization at the initial segment of the pyramidal cell. Thus, when CP3 and CP4 sites are used, using this arrangement, we get a fair direct response, but some distortion will occur and there will be lack of reproducibility from one trial to the next. Another option is to bring the electrodes closer, corresponding to CP1 and CP2. The response obtained using this placement tend to be more compact and more reproducible than the one we mentioned before. Regardless of the stimulation electrode placement used, the D wave rostally, that is from the cervical spine and caudally from the thoracic spine, has a slight difference in amplitude, but rather similar configuration. And the peak latency of the caudally recorded D wave is, as expected, slightly delayed when compared to the proximally recorded D wave. In normal individuals, the D wave generated with right hemisphere should look about the same as the one recorded when stimulating the left hemisphere. But even in the presence of a significant difference, amplitude and morphology differences are not reliable parameters to decide if there is a significant abnormality. it is only the presence or absence of a D wave that can be used to determine normalcy or abnormalcy. So the answer to this question is C. Next question. Which of the following stimulation sites is the best to produce a muscle motor evoked potential? A, B, or C? When it comes to getting a muscle motor evoked potential, which tend to be larger in the lower extremity than in the upper extremities, the best site for stimulation is to place the anode behind CZ and the cathode 6 centimeters in front of CC, which corresponds to about FC. So the answer to this question is B. Which of the following steps can be taken to increase the probability of capturing tibialis anterior muscle motor evoked potential? A. Use a facilitatory stimulus. B. Place the anode close to ZZ. C. Use a ring of 4 cathodes 6 centimeters from ZZ. D. All of the above. In difficult cases, when no muscle motor evoked potential is generated using the regular arrangement, we can do several things to see if somehow we can generate a stable muscle motor evoked potential so that we can monitor it during the surgical procedure. This obviously should be done before surgery starts and with the patient sedated. The first thing to do is to make sure that all electrodes and the equipment are in fine condition. This includes checking the electrodes, impedance, and the equipment for electrical problems. The second thing is to prep the muscle being monitored prior to the stimulus. This is done by low amplitude repetitive stimuli prior to the stimulating train intended to provoke the potential. In this example, no prep stimulus was given to the left plantar arch prior to transcranial stimulation. But here it was given in the right plantar arch of the tibialis anterior. Following transcranial stimulation, the muscle motor evoked potential is only recorded from the right. That is the place where the facilitatory stimulus was given. This facilitatory trial consists of repetitive low-intensity stimulus, as we just mentioned, given close to the muscle being tested. In this case, the stimulus was given in the right plantar arch. This facilitatory trial should be given 60 minutes prior to transcranial stimulation. The facilitatory trial should consist of 10 pulses with a duration of 0.5 milliseconds each, using a stimulus intensity of 20 to 60 milliamps at a rate of 500 Hz. The third thing that we can do is to create a ring around the anode by placing 4 cathodes 6 centimeters apart from the anode. The anode is placed at CC, as you can see in this frame. So the answer to this question is D. Next question. Ketamine increases cortical somatosensory evoked potential and muscle motor evoked potentials. A true, B false. Ketamine is a good friend of neurophysiologists. Using a mixture of nitrous oxide, fentanyl, and ketamine during an operation, you can see the tibialis anterior muscle motor evoked potential. Compare the amplitude and configuration with the potential obtained prior to initiation of anesthesia and after anesthesia was stopped. As you can see, during anesthesia, the response is higher amplitude and more robust. So the answer to this question is A. Next question. Facilitatory trials can be used with ketamine-induced anesthesia to provoke muscle motor evoked potentials. A true, B false. This frame depicts the difference between prepping an anterior tibialis muscle with pretrial stimulation when using propranolol-based anesthesia and when using a ketamine-based anesthesia. With propofol anesthesia, no potentials were recorded, despite facilitatory stimulus being given. With ketamine anesthesia, potentials were recorded, prepping the muscles before the actual transcranial stimulation. Using no facilitation and ketamine-based anesthesia, flexor ulnaris muscle motor evoked potential were elicited in this patient. The point being that at times you cannot elicit in one muscle, but you may elicit it in another one. This may have to do with the position of the electrodes or the stimulation sites at the level of the scalp. So the answer to this question is true. Next question. The 4 trial test can be used to determine the reliability of muscle motor evoked potential to predict an injury in the motor pathways. A true, B false. The train of 4 monitoring is a peripheral nerve stimulation test used for neuromuscular blockage monitoring. The response of a muscle in this frame, the abductor pollicis 2, 4 single supramaximal ulnar nerve stimulation is shown. It is often used, that is, this test is often used by anesthesiologists to decide on the degree to which muscle are paralyzed and therefore the amount of paralyzing agent to give. In clinical neurophysiology, the test is used to determine when the loss of muscle motor evoked potential is a reliable indicator of an injury in the motor pathway versus the result of excessive blocking of the muscle. In this new frame, I have represented 5 different scenarios, just as they were represented numerically in the prior frame. The first, pointed by the arrow, corresponds to no muscle blocking being present. That is, 4 of the 4 single supramaximal stimuli resulted in a muscle motor evoked potential. For the neurophysiologist, this indicates that if muscle evoked potentials disappear, a lesion is likely to be present in the motor pathway. In the last one, no potential was recorded in any of the trials, representing total neuromuscular blockage. If muscle motor evoked potential is lost in this situation, we cannot tell if the problem is due to excessive neuromuscular blockage or an abnormality in the motor pathways. Under the rectangles, I will represent the actions that may be taken by the surgeon on recommendation from the neurophysiologist based on the findings in this test. As you can see, I have placed 3 lines to represent the different approaches. All the neurophysiologists agree that the recommendation, when all 4 or at least 3 potentials are present, that the testing, that is the result of the muscle motor evoked potential, is reliable to make decisions. All neurophysiologists agree that when 0 or 1 potential is triggered, despite the usage of pre-paralyzing agent supramaximal stimulus intensity, muscle motor potentials cannot be relied upon to make decisions. When only 2 of the 4 stimuli produces a potential, not all agree on the reliability of muscle motor evoked potentials, and my advice is not to be used in such instances. So the answer to this question is true. Next question. D-wave monitoring offers substantial advantages over muscle motor evoked potential monitoring during thoracoabdominal aneurysm surgery. A true, B false. In this frame, I will show the effect of oxygen deprivation upon D-wave and muscle motor evoked potentials. In the first instance, you can see that when the spine is well oxygenated, that is, the gray matter and the white matter are both oxygenated, both potentials can be recorded. With some oxygen deprivation, the D-wave persists because the D-wave is generated by the white matter, which is rather resistant to oxygen deprivation, whereas the muscle motor evoked potential will disappear because they are generated by neuronal activation, which require more oxygenation. Both D-wave and muscle motor evoked potential will disappear if oxygen deprivations become severe. Thus, since monitoring we want to determine the possibility of an injury as early as possible, muscle motor evoked potential are better suited for this endeavor than D-wave monitorization. In addition, D-wave can only be reliably obtained with transspinal monitoring, that is, with direct monitoring of an open spine. So the answer to this question is B. Next question. Which of the following is not true regarding D-wave? A. D-wave is not found in 30% of adult cases. B. D-wave cannot be used below T11, T12. C. D-wave can only be recorded using an epidural electrode. D. D-wave are more often monitorable in children than in adults. No D-wave can be recorded below T12. This is so because below T12 or T11, the volume of the spinal cord white matter is very thin. Hence, the spinal tracts that are the generators of D-wave are very small and cannot generate the potential. Notice in the added figure the difference in size of the white matter in relation to the gray matter in the low spine compared to at a much higher level. Another characteristic of D-wave is that it can only be recorded during spinal cord surgery with exposure of the epidural. The claim by some investigators that it can be obtained using percutaneous needle have so far not been widely substantiated clinically by others. Our ability to capture D-wave changes with age, perhaps as a function of synchronicity. After 36 months of age, D-wave are obtainable in about 66 to 80% of trials, and it has good reliability. From 21 to 36 months, D-wave are present in 50% of the cases, and synchrony is fair. In patients less than 21 months of age, D-wave is not usually present, and when present, synchrony is poor, casting doubt on their reliability. So the answer to this question is D. Next question. The loss of muscle motor evoked potential during thoracoabdominal aneurysm surgery always occurred during intervention involving the artery of Adamkiewicz. A true, B false. This frame shows some of the relevant anatomical points regarding thoracoabdominal aneurysm surgery. The aorta, the left posterior intercostal artery, the posterior branch of the posterior left intercostal artery, This artery, as you can see, provides spinal irrigation. The segmental spinal artery, by the way of the segmental medullary arteries, which feed the anterior spinal artery. In addition, the segmental spinal artery gives two more branches: the anterior and the posterior radicular arteries. These arteries, by crawling on the roots and rootlets, reach the spinal cord. Yet there is a great variability in spinal cord irrigation. I will show you a slight different arrangement in this frame. As you can see, from the posterior intercostal artery arises the spinal branch of the posterior intercostal artery, which divides into the radicular posterior artery and the anterior radicular artery. This artery, instead of irrigating the spinal cord by entering the spinal canal through the roots and rootlets, it goes towards and makes a large artery that connects with the anterior spinal artery. In this case, since it has taken place at the level of the thoracic spine, we call this artery the artery of Adam-Kiewicz. The artery of Adam-Kiewicz irrigates a large portion of the thoracic and even number spinal cord segments. Before leaving the discussion about irrigation of the spine, I'd like to show you a few more points regarding it. This time I'd like to look at the big picture. Depicted in this frame, you can see from the aortic arch to the caudal bifurcation of the aorta. Here I have indicated the left carotid artery. Now I have indicated the T1 to T2 left posterior intercostal arteries. Below, you can see the lumbar posterior intercostal arteries and the bifurcation of the aorta. In this lateral view, you can see the main arteries traveling to irrigate the spinal cord. Obviously, this is being represented only from one side because the arteries usually arise from the left and the right side of the aorta. The artery of Adam-Kiewicz is only one of the arteries going from the posterior intercostal artery to the spine. Injury to any of the arteries irrigating the spine can produce a spinal injury for which the artery of Adam-Kiewicz could not be able to compensate. The artery of Adam-Kiewicz arises from the left side in 80% of the cases and from the right side in the rest, but there's only one artery of Adam-Kiewicz. So the answer to this question is B. Next question. During thoracoabdominal aneurysm surgery, a pump is needed to maintain the circulation below the location of the aneurysm. A true, B false. During thoracoabdominal aneurysm surgery, a pump is needed to maintain the circulation below the area of the aneurysm during surgery. So the aorta circulation is maintained and thus spinal cord circulation is also maintained. So the answer to this question is A. Next question. Transcranial electrical muscle motor evoked potential is the study of choice to detect spinal cord ischemia during thoracoabdominal aneurysm surgery. A true, B false. The study of choice to monitor the spine during thoracoabdominal aneurysm surgery is transcranial electrical stimulation provoking a muscle motor evoked potential, as I will depict in the following frames. The tracing just introduced corresponds to a pre-surgical baseline obtained in a person on being ready to undergo surgery. Then the aortic pump is placed. After starting the distal perfusion, the first surgical potential was obtained, and as you can see, they look robust. Then rostral aortic clamping took place in this instant, and 5 minutes after a potential was obtained, we show no significant difference from the pre-surgical one. Then 30 minutes after clamping the rostral arterial area, a second potential was obtained, which again show no significant change. The period of time lasting 30 minutes from the time the rostral aorta clamping to obtaining a second evoked potential constituted the thoracic portion of the operation. Then the distal aorta was clamped and 2 lumbar segmental arteries detached. These were the first step of the abdominal part of the operation. 1 minute after clamping the aorta and detaching the 2 lumbar arteries, the first potential was obtained during the abdominal part of the surgery. As you can see, it shows significant drop in the amplitude of the potentials. Further, transcranial muscle evoked potentials were obtained at 2 and 3 minutes after distal aortic clamping, and in both occasions no potentials were generated. The loss of potential prompted the reattachment of the lumbar arteries and the reperfusion of the segment. It took 20 minutes after reperfusion was established for minimal potentials to emerge, which significantly improved after 25 minutes of reperfusion. And after 30 minutes, the potentials look very robust. So the calculated spinal ischemia time was 23 minutes from the time of lumbar segmental artery detachment till 20 minutes after reattachment has taken place. 2 days after the operation, this patient appeared to have become paraplegic. Muscle transcranial motor evoked potential were absent from both tibialis anterior muscles at the time, and geographic examination revealed thrombosis of both grafted lumbar arteries. The artery of Adankowitz was not reported involved. So the answer to this question is B. Next question. Transspinal electrical stimulation is mostly done when patients have a contraindication for transcranial electrical stimulation. A true, B false. Transspinal magnetic or electrical stimulation may trigger muscle motor evoked potentials, D waves, and nerve motor evoked potentials. This procedure is more cumbersome than cranial stimulation. Spinal cord is usually done when there is contraindication for transcranial monitoring, like the patients that have epilepsy, or at times it is also used in infants when a spinal cord stimulation is required in order to record from the shoulder girdle muscles, for example in patients with brachial plexus palsy. The reason that we use spinal stimulation in these cases is because it's very difficult to find a place to proximally stimulate the shoulder girdle muscles in children. So the answer to this question is A. Next question. Please take a few seconds, a minute if you must, to read this paragraph and then try to answer the correct answer. A. Transcranial magnetic stimulation with spinal epidural monitoring. B. Transspinal magnetic stimulation with muscle recording. C. Direct spinal electrical stimulation with direct nerve recording. D. Direct spinal electrical stimulation with superficial muscle recording. The first step to select the best test for a job is knowing your options. The decision to choose one versus another motor evoked potential modality is based on understanding the areas that the different modalities can survey and the indications and limitations of each modality. The two most important parameters are related to stimulus and response or recorded potential. The type of stimulus theoretically available are magnetism and electricity. This stimulus can be provided transcutaneously, that is applied to the skin, or the stimulus can be given directly or in close contact to the site of the nervous system we're trying to stimulate, that is either during surgery or by inserting a needle. Magnetic or electrical stimulation needs to be considered based on location of the stimulus that is being applied. The possible sites of electrical stimulation are the scalp, which is labeled cranial, spinal region, and the skin above the nerve we want to study. Or at least theoretically, electrical stimulation can be given directly over the brain, the spine, or the nerve if these structures are exposed. I think it is important to stress that the use of magnetism to directly stimulate the nervous tissue is only done experimentally. Electrical stimulation can be thought of on the same basis. Transelectrical stimulation can be applied to the scalp, which is labeled transcranial electrical stimulation, to the spinal region in the back, which is labeled transspinal electrical stimulation, or it can be applied through the skin to the nerve. Electrical stimulation can also be applied directly to the brain, spine, and nerve. All these possibilities relate to the stimulus modalities. Now I like to consider the response to that stimulus. And again, I will first address the issue of the recording location. Recording can be done by electrodes in the epidural layer of the spine, from the nerves, or from the muscles. So based on the recording site, we can label motor evoked potential as spinals, to which we have been referring as D and I wave, from the nerve, to which we refer to as nerve motor evoked potentials, or from the muscle, to which we refer to as muscle or myogenic motor evoked potentials. Based on the method of gathering the information, to which we will refer as reception or recording, we can record from the spine, done transcutaneously or directly. Transcutaneous stimulation recording is not clinically possible, and therefore we have no label for it. the labeling for direct spinal cord recording is D or I wave, as we have previously mentioned. When nerve motor evoked potentials are obtained by transcutaneous recording, the label is usually N motor evoked potential, and a T is added at the end. When the response is recorded using needle close to the nerve, then to the N motor evoked potential we add the T at the end. When muscle motor evoked potentials are obtained by transcutaneous recording, then we use M EP and put the T at the end, but this is hardly ever done, since most of the time we evaluate the muscle by recording with the needle inserted in the muscle, and this way we label the study MED and add the D at the end. Once we know all our options, the second step is choosing the receptor or recording site. In a situation which the patient will undergo surgery using a strong paralysis, it is important to try to stay away from recording from the muscle, since the muscle will be vulnerable to paralysis. If we go back to the general chart that I show you, where I give you all the options, we can thus remove from those options those potentials recorded from muscle, as I have done in this frame. And then we need to consider whether we should record from the spine. In this case, since the patient's involvement is in the lumbar spine, and as you know, D waves cannot be recorded at that level because the spinal cord doesn't reach that low, then we will not be able to monitor D waves. So we will be left with only one possibility, that is to monitor nerve motor evoked potentials. Nerve muscle evoked potentials are better recorded directly, that is with a needle close by to the nerve, because otherwise we will get too much artifact. The third step is to select what is the best mode of stimulation. We already know in this patient that we're going to be monitoring directly from the nerve, so now we got to decide what is going to be the stimulus that we're going to use and where will the stimulus be given. The possible methods of stimulation is magnetism or electricity, and the possible site of stimulation are the brain, the spine, or the nerve. Nerve stimulation, although a theoretical option, is not a real option, since the problem is in the spine and the principle of monitoring is to stimulate above the lesion and record from below it. Direct spinal stimulation, since the area will be exposed during surgery, makes the most sense, so cranial stimulation will not be done, and instead we will prefer and we will do spinal stimulation. Next in the decision algorithm is the mode of stimulation, that is magnetism or electricity. electricity is most readily available and more ore friendly than magnetism. Hence, it's more appropriate to use electricity. The next question will be whether to use it transcutaneously or directly in the spine. Since the spine will be exposed by the surgical needs of this patient, it is more appropriate to use it, since we get better results from a spinal stimulation than we do from transcutaneous stimulation. So, monitoring was done using direct spinal stimulation, as seen in this enlarged view. Recording was performed using the posterior tibial nerve using subcutaneous needles. And the answer to this question is therefore C. Next question. During a spinal surgery, an increase in latency of more than 10% and in amplitude of more than 50% of a direct neural motor evoked potential should make you think of A. Traction upon vulnerable region, B. Ischemia proximal to the point of stimulation, C. Myogenic contamination of the potential, D. All of the above. This frame represents a patient with an L1 fracture and 50% encroachment presurgically. The spinal cord needed monitoring, and because neuromuscular blocking was going to be used, the recording was done by placing a searching needle electrode in the thigh at the level of the popliteal fossa and referring it to an electrode about 4 to 5 centimeters distally. The stimulating cathode was placed distally under the dorsal process of T9. The anode was placed rostally. The filters used for nerve recording were a low frequency filter of 10 Hz and a high frequency filter of 3000 Hz. The stimulus intensity used was 30 milliamps. A rate of stimulation was 4.7 Hz and the duration of each pulse was 300 microseconds. Using these parameters, the first study was done before surgery, and the tracing on the left side of the screen was the result of it. As you can see, the peak latency was 13.9 on the left and 14.2 on the right, and the amplitude was 0.99 microvolts on the left and 1.58 microvolts on the right. Surgery was started, and 20 minutes after or so, the test was repeated using the same settings. In this instant, the nerve motor evoked potential that was obtained was quite different from the one that was obtained pre-operatively. The latency was much higher. It had increased by 30% on both limbs, and the amplitude was also greatly increased, as you can see in this figure. After this recording, the patient was given more muscle relaxant, and within 5 minutes another trial was done. This trial showed that the value had returned to the presurgical numbers. So what happened in this case was that the increase in latency and amplitude of the potential between the preoperative nerve motor evoked potential and the first operative nerve motor evoked potential resulted from poor paralyzation, and therefore was a contaminant. And when this was corrected by increasing the paralysis, the second nerve motor evoked potential reflected the fact that there had been no significant change. So it was the same as it was pre-surgically. So the answer to this question is C. Thank you very much for your attention.